pediatric population. Now, I will honestly tell you that we spent a lot of time on Monday talking about, both acute and chronic sort of kidney disease and kidney failure. So we didn't spend a lot of time on other things, other urinary tract or kidney disorders that may affect adults. So we're going to look through a lot of these conditions through the sort of lens of the pediatric population today. But that's not to say that some of these things that we're going to talk about today wouldn't necessarily also impact an adult population. We just didn't talk about it on Monday because I wanted to spend so much time on the complexities of renal disease. So we kind of are able to sort of hit it from two angles today, which is sort of a good thing. We have about an hour, so we'll probably get through most of this. And then whatever we don't finish today, we'll have time on Monday to finish before we dive into our group case studies. Okay? All right, let's get started. Here are your objectives for the pediatric content. And you'll see today as we move through the morning that I'm going to sort of divide up the different abnormalities by either sort of structural, which are not things that you will normally see in the adult population, because a lot of these structural abnormalities are sort of congenital abnormalities that get fixed very quickly after birth, surgically or, intervention-wise. So a lot of these sort of structural things we're going to talk about first you won't see in an adult population, but then as we move through the morning, we'll talk more about sort of filtration, glomerular type conditions, and those you could certainly see not only in the pediatric population, but with adults as well. Okay, so just wanted to sort of say that on the outset. Okay, so first thing, structural abnormalities. And again, this is going to be pretty specific to kids, pretty specific to pediatric population. And we're kind of just going to go through kind of like a little tour de structural abnormalities. There's kind of just like a list here that we'll kind of work our way through. So the first one is horseshoe kidney. This is literally a kidney that is like basically two kidneys kind of fused together. So normally when the embryo or when the fetus is growing, the kidneys sort of as they sort of grow up out of the abdominal cavity and sort of find their places in the correct anatomical spot, they sort of pull apart, right, and become two kidneys. Well, in a horseshoe kidney, the kidneys sort of fuse as they ascend into the abdomen. So they actually kind of come together and cause a single sort of U-shaped kidney in that lower sort of flank, lower back area. This may not cause a problem at all. In fact, a third of children that have a horseshoe kidney are completely asymptomatic. So the nephrons in that fused kidney are still sort of working and able to sort of filter blood, and there's really no symptoms. But that's really only a third. The most common problems that you're going to see in horseshoe kidney are hydronephrosis. And I very briefly touched on that on Monday. What is that? What is hydronephrosis? Anybody remember? I think I anecdotally sort of mentioned it on Monday. It's basically excess fluid, excess water, so water in the kidneys. Excess fluid up in the kidneys. Anytime you've got excess fluid or you've got stasis of fluid or stasis of urine, you're at risk for infection, stone formation. And then because of the sort of inflammation and the trauma that the cells in that horseshoe kidney sort of take on, they can be more at risk for renal malignancy, so developing some sort of renal cancer from those abnormalities in horseshoe kidney as well. So that's horseshoe kidney. Now, and that can affect both, baby girls or baby boys. Now, the next two, hypospadias and epispadias, are two urethral structural abnormalities that affect only boys. Only males are affected with these two. And you'll kind of see why as I talk through them. So hypospadias is where the urethral meatus, so the opening, of the urethra, is located sort of on the underneath, on the ventral side of the penis. So instead of it being, at the tip as it normally is located, it's actually sort of underneath that, on the bottom part of the penis. And I'll actually have a picture for you in just a second. Again, this may not cause an issue, but the issues lie in that sometimes because of where that's located, it kind of pulls and sort of tightens on that tissue there. And so it causes what we call a chordae, which is basically sort of the skin getting tethered and sort of shortened and pulled, of the subcutaneous tissue around that area that actually causes the structure to actually bend. So that's one complication that can happen with hypospadias. Oftentimes, not only just the pure hypospadias, but also then if there's a chordae associated with it, corrective surgery is usually done to sort of put the urethral opening in the correct anatomical spot between about 6 to 12 months of age. So that's kind of a sort of classical sort of way hypospadias kind of is sort of taken care of and sort of evolves. Then the other one, epispadias, is where the urethral meatus is on the dorsal side of the penis. And so what I mean by that is sort of the top. And it's certainly more complex and more difficult in terms of treatment because oftentimes the urethral meatal sort of opening is so far up on that sort of top side of the penis that it almost is sort of like right where the body, where the abdominal wall sort of joins the penis. And so the hole can actually extend right into the abdominal wall, into the bladder. So this is more of a complex structural abnormality than what hypospadias is. And so obviously corrective surgery is needed for this pretty quickly after birth as well. The issue with, so still 6 to 12 months, if not even earlier, because of the issue with the bladder being involved as well. And oftentimes this type of corrective surgery is needed to be done more in sort of stages because of how it actually impacts the abdominal wall and impacts the structural sort of integrity of the bladder as well. So that's the difference really between hypospadias and epispadias. All right. And then the last one on this slide is exstrophy of the bladder. So this is literally where the bladder is on the outside of the body in these babies. So it's a herniation of the bladder through the abdominal wall. And it really happens because there is a bladder and a pubic defect in which the bladder just kind of, as the fetus is forming, it just kind of falls out of the body because there's sort of a the rectus muscles, which are those the abdominal muscles that are sort of in the low abdomen, are separated. The pubic bone oftentimes is not completely fused in the front, so that also creates a gap and a hole. And so the bladder just is sort of protruding outside of that abnormality. Both the bladder and the pubic defects are usually closed pretty quickly again after life. About 72 hours is sort of the goal range of when they'd like to get that corrected. But there's a lot of different types of surgical reconstruction that has to happen within that first year of life. So it's a multi-stage sort of surgical intervention. Oftentimes because, and this is kind of just an anecdotal sort of little comment, oftentimes because of the way that the pubic bone is not fused, that if it's, if that's not part of the surgical sort of intervention yet and the baby starts to learn how to walk, they have first of all difficulty learning how to walk. And when they do learn how to walk, they have a very sort of waddling kind of gait because of that abnormality in their pubic bone. As they get better and as they get more sort of adept at walking, that waddling gait kind of goes away. But it's something you certainly see in these babies or in these toddlers because of that abnormality in the pubic bone. Now, this is something totally fixable. It's not anything that is going to sort of affect the sort of lifespan of this baby. And luckily, because it is a very sort of structural problem, you can find it even before the baby is born. So usually when the baby is born, they know about it already because of intrauterine ultrasound. So prenatal ultrasounds can certainly very clearly show exstrophy of the bladder. So as soon as the baby's born, they've already made plans for reconstruction and fixing this problem. And that's kind of exstrophy of the bladder in a nutshell. And again, to be clear, exstrophy of the bladder can affect both boys and girls. So it's not necessarily just males, the way the hypo and the epispadias is. And here's some really actually very sort of good sort of illustrative pictures for you. This is a great picture of hypospadias, and that you see that urethral meatal opening on the bottom side of this little newborn's penis. You can see, should be here and it's way underneath. And this is a great picture of the chordae. Because of that opening being down here and the way that it pulls on that subcutaneous tissue, it actually changes the structural sort of form of the penis. And so those are really good pictures of hypospadias for you. So that's a pretty significant chordae there. And then here's a really good picture of exstrophy of the bladder. So you can see, this is obviously this little baby boy, you can see kind of the structural abnormalities of his pubic bone, how it sort of looks flat and not normally sort of shaped. And again, sort of the same sort of structural abnormalities of these abdominal muscles right here. Again, they look sort of separated and flat and doesn't look how a normal sort of lower abdomen should look on a baby. This is a great picture. So this beefy red organ right here is the bladder, laying just right outside of the abdominal wall. So a lot of, like I said, reconstructural surgery will sort of take place for that. Okay. Any questions about any of those that we've talked about so far? Okay. Pretty straightforward structural type abnormalities. Okay, moving on in our tour to structural abnormalities is bladder outlet obstruction. Now this is something that you won't see near as commonly as some of the other things that we've just talked about. It is rare. But what it basically is that someone or a child with bladder outlet obstruction has these strange little valves or polyps inside the urethra itself, sort of inside the lumen of the urethra. And valves are not normal in the urethra. We don't normally have any sort of valves the way we have valves like in our veins. That's not normally there. Same with polyps. Polyps are sort of like little little sort of outpouching of the internal lumen of the urethra. That's not normal. And they want to be resected as soon as possible, as soon as detected. Why do you think that might be? Why do you think these thin little membranes of tissue, like these valves or these polyps, would cause a problem? Why would we want to get them removed as soon as we find them? Mm-hmm. Yeah, they cause obstruction. They cause urethral obstruction, which, as you can imagine, could cause a lot of issues with urinary outflow, and then you have, sort of backup of that urine, causing issues with the bladder, and then eventually having so much backup that you're causing issues with reflux back up into the kidneys. So we want to get rid of these as soon as possible. And interestingly, the babies that have the polyps in the urethral lumen are usually males, because the polyps usually form kind of in and around that prostatic area of the urethra. So that's more commonly in males, obviously, than females because of the presence of a prostate in boys. Great. All right, and then the next one, kind of a mouthful, ureteropelvic junction obstruction, UPJ, is a blockage of the tapered point where the renal pelvis transitions into the ureter. Remember last week when we talked about the structure and sort of the anatomy of the kidney, and that right as the urine sort of leaves the kidney, it goes through that area, that sort of pyramid-shaped thing in the middle of the kidney called the renal pelvis that sort of turns into the ureter. That's where there's sort of a tapered, sort of strictured area, a tight area, and that obviously that then blocks the flow of urine out of the kidney. It causes an obstruction. There's primary ureteropelvic junction obstruction, which can be sort of one of the main reasons for hydronephrosis in a neonate. So hydronephrosis, again, meaning that backup of fluid, that backup of urine. But there's also secondary UPJ as well. And oftentimes a secondary reason for UPJ would literally just be because there's some sort of kinking or some sort of scarring in that area that causes a stricture and causes a narrowing of that outflow of urine out of the kidney. Surgery is definitely needed to relieve that obstruction, especially if there really is a significant decline of drainage and therefore obviously renal function. So this is usually a surgical fix to this type of condition that UPJ is. And then lastly on this slide, you see hypoplastic or dysplastic kidneys. Hypoplastic kidneys, hypoplastic kidney, I should say, is basically just a kidney that's smaller with a decreased number of nephrons. So the nephrons that are present might be perfectly normal. They might work perfectly fine. There's just an overall decreased number of the nephrons. If only one kidney is hypoplastic, so if you basically have like a unilateral hypoplastic kidney, there really is no problem or any issue at all. You're just going to always have one kidney that's sort of smaller than the other. Interestingly, if this is the case, quite often the other kidney will sort of become enlarged over several years to kind of compensate and sort of take over that sort of hypoplastic other kidney. But really there is no other defect if only one kidney is involved. Now, if you have bilateral hypoplastic kidneys, we're probably talking about a chronic renal failure situation in these babies. And then we're talking about issues with, do they need a transplant? Is this something that's going to affect their whole life and their whole sort of health of their life? So that's something you should have to think about. Is it unilateral versus bilateral? And then dysplastic kidney basically results from abnormal differentiation of renal tissues. So what I mean by that is, in these type of kidneys, these dysplastic kidneys, it's really characterized by just funky structure. So really primitive, sort of non-functioning glomeruli and tubules. You'll see a lot of cysts, sort of abnormal little growths in these kidneys. And you'll also see tissue that shouldn't necessarily be there. So sort of non-renal tissue like cartilage and other sort of funky types of tissues that are not normally found in the kidney. That's sort of your classic sort of stereotypical patho of a dysplastic or a dysplasia kidney. Again, may need transplantation. These are babies that might be on the list for organ transplantation. Okay. And then the last two of the structural abnormalities is polycystic kidney disease. This is an autosomal dominant inherited disease that's basically characterized by multiple cysts that just continuously appear, grow, proliferate, that interfere with renal function. If you remember when I talked about reasons for chronic kidney disease on Monday, and I showed that graph, diabetes and hypertension being number 1 and number 2, kind of farther on down that list on that graph was polycystic kidney disease. So even though it's not one of the major reasons for chronic renal failure or need for transplantation, it's certainly one of the reasons. And you see it as early as, babies in the pediatric population. So that's polycystic kidney disease. And basically, sort of like what I said, pathophysiologically, it's just these really large fluid-filled cysts of the tubules and the collecting ducts. And then so what sort of problems do you think that causes when you've got cysts in the tubules and the collecting ducts and sort of in that tubular system? So it can certainly cause infection because it's going to cause backup of the fluid. Yep, yeah, and what else? That's good. How about issues with absorption and secretion, right? If you've got these big fluid-filled cysts in those areas, that proper sort of movement of fluids and particles back and forth across that filter between blood and urine is certainly going to be impacted and obstructed because of these big cysts sitting in the way. So that's why polycystic kidney disease is really so considerable in terms of a reason for chronic kidney disease. And then 9, renal agenesis is really the absence of one or both kidneys. So if it's unilateral, again, the remaining kidney, kind of like what I talked about with the hypoplastic kidney, will often, the normal kidney will often completely be normal. The child has a normal, healthy life. The kidney may be larger, the functioning kidney may be larger because of there is no other kidney, right? So, but they can live a pretty normal life. As opposed to obviously bilateral renal agenesis, so there's no kidneys. Pretty rare, but obviously you can imagine, just completely incompatible with extrauterine life. So these babies, unfortunately, will pass away, will die pretty soon after birth if they don't own, either kidney. And again, this type of structural abnormality can be detected even before the baby's born, prenatally by ultrasound. So again, certainly more rare to have a bilateral, lack of kidneys as opposed to the unilateral, but when it does happen, it is compatible with life. All right, so that really is the end of our structural abnormality discussion. Any questions about that? Anything I can sort of sum up for you or make more clear to you before we move on to more of sort of the glomerular, sort of more complex filtration problems? Any questions for you? Okay. All right. So that being said, we are going to move more into glomerular disorders. And really, when you're talking about glomerular disorders, not only here in the pediatric population, but also with adults as well, when we're talking about glomerular disorders, we're talking about a disorder called glomerular nephritis. Has anyone heard of that? Anyone familiar with that at all? Maybe through clinical or personal experience or whatever it may be? Again, very quickly, I sort of touched on it on Monday in talking about reasons for that intra-renal reasons for acute kidney injury, and I mentioned sort of acute glomerular nephritis, and I didn't really sort of go into why it would cause an intra-renal problem, because we're going to do it today. So let's talk a little bit about what glomerular nephritis is. Just from the name, what do you think it is? Glomerular nephritis. Death? What does itis mean? Inflammation, infection, good, right. Perhaps it's more of an inflammatory type of thing than true death or necrosis. So inflammation of the nephron and of the glomerulus, really, is what glomerular nephritis is. And really it includes a number, it's sort of the umbrella term for a number of different renal disorders in which basically what you see is overproliferation and inflammation of the glomeruli. And most of the time, and in all the reasons that you sort of see here on the screen, most of the time some type of glomerular nephritis is going to occur sort of secondarily to some sort of infection. Some sort of other infection, meaning upper respiratory infection or a skin infection or something like that. So there is sort of this inflammatory sort of immune component to glomerular nephritis, no matter which kind of reason that we're talking about here. But again, usually some type of, sort of associated with some type of infection prior for the glomeruli and the nephrons to be attacked. So let's talk a little bit more specifically about these three sort of subtypes that I have here on the slides that, again, are all sort of considered a form of glomerular nephritis. Okay, so the first one is acute post-streptococcal glomerular nephritis. Now, this is sort of your classic stereotypical glomerular nephritis that occurs post a streptococcal infection. So it occurs after usually like a throat or skin infection with specific types of, or shall I say, specific strains of bacteria, of a strep. But what you see and sort of what the patho is of this is that you'll see these, again, remember I said it kind of is associated with an abnormal sort of immune response. So it's associated with this deposition of these antigen-antibody complexes in the glomerulus that damages the endothelium and sort of the endothelial cells in that glomerulus. So it causes basically damage and inflammation of the capillaries, right? Remember the glomerulus is the little tuft of 50 or more capillaries that starts the filtration process. So if you've got these antigen-antibody complexes that are causing damage to the endothelial cells of those capillaries, what do you think is going to be the problem? I mean, what is the initial problem right there that sort of brings a red flag to your mind? What starts there in the glomerulus? Urine, the filtration of urine, right? So if you've got issues with those capillaries already, before you've even moved through the nephron into the tubular system, you're having issues with filtration, okay? And that's the major problem with glomerular nephritis, is that you're already impacting filtration and the beginning of urine. So you're going to see lots of problems when you're already impacting the very start of urine. So oftentimes what you'll see because of that pathophysiology is that you'll see a very sort of sudden, abrupt onset of hematuria. So you'll see gross, sort of frank blood in the urine. You'll see proteinuria. Why might you see proteinuria in glomerular nephritis? And it's not, I'll tell you, it's not just this one type of glomerular nephritis. It's any of the glomerular nephritis that we're going to talk about. Why might you see proteinuria? What do you think? Mm-hmm. Right. The protein, like a plasma protein like albumin, is supposed to stay inside our capillaries, right? And sort of create and sort of remain that oncotic osmotic pressure. So exactly. So if there's damage to those capillary beds, that protein has a greater ability to sort of leak through those damaged capillary beds and leak from the blood into the urine. So that being said, if you've got a lot of protein in your urine, are you going to have a lot of plasma proteins in your plasma where it should be? No. So then given that, what do you think some of the other issues that you might see might be? What symptomatology would you see if you've got low levels of albumin in your blood or low plasma protein levels? What's going to happen? It's on the screen. Edema, right? So you're going to see pretty profound generalized edema because you've lost all your protein now in your urine. There's none left in your capillaries, in the bloodstream, to sort of keep that fluid in and keep that oncotic pressure at a normal level. You may see hypertension just basically not so much because of the protein issue, but because of there's a filtration problem, right? So they may not be losing and getting rid of that excess fluid that they should be, and causing hypertension. Very, very much the same exact reason for hypertension that we talked about on Thursday, or Monday, when we talked about hypertension and chronic kidney disease. It just has to do with the lack of secretion of water out of those tubules and out of the body. And then obviously renal insufficiency because your glomeruli aren't working. And again, usually you'll see this within about 1 to 2 weeks after an upper respiratory infection, and maybe a little bit later with a skin infection, maybe 6 weeks to almost 2 months. You'll start to see this. So really important in terms of clinicians, when you see someone coming in with kind of these kidney issues, this edema, hypertension, kind of some of the same signs and symptoms of of kidney disease that we talked about on Monday, but it's sort of out of the blue, very acutely. A good question to ask in the history is, have you had any other sort of illnesses in the last couple of months? And specifically ask about upper respiratory infections or skin infections, because again, that abnormal immune response can certainly then sort of down the road impact the sort of integrity of the glomeruli. So kind of funny to think about that something like an upper respiratory infection could sort of impact your glomerulus, but it certainly does happen, and it could happen to anyone. Doesn't mean that that they're more at risk because they're sickly or that they have some other sort of possessed position. It could literally just be anyone that their glomeruli are attacked by this abnormal immune response. So that's an acute sort of post-streptococcal glomerulonephritis. Again, we sort of talked about, I mentioned it sort of 2 slides ago, and sort of those subtypes of glomerulonephritis, immune globulin A nephropathy. Again, characterized by deposition of some sort of abnormal immune globulins. In this case, immune globulin A, thus the name. Sometimes there's a little bit of M in there as well. But again, same patho as what we just talked about with the previous type of bacteria that impacts the glomerular capillaries. It causes inflammation, destruction of those capillaries. And again, deposits of immune globulin A cause immune injury to the glomerulus that usually is reversible. So that's sort of one good thing. Not only about this, but also about acute post-streptal glomerulonephritis. The good news, even though this can make someone super sick, both this one and this one, the good news is that it usually does just sort of run its course in about a month or so. So usually it's pretty self-limiting, that damage to the capillaries in the glomerulus are not permanent, but it does take a while. So it'll take about a month or so for this to run its course. But even when the urine content sort of comes back to normal, so even when you're not seeing that proteinuria and you're not kind of seeing, some of those other changes to the urine, other symptoms may last a while. So it just sort of depends on, how fast they're sort of getting over it. Totally depends. So one person, even though they're kind of starting to sort of resolve this within a month or so, might still have some type of symptomatology for a while. Maybe even a year or so, have some type of sort of renal insufficiency. But again, the good news is greater than 95% recover completely. And really the treatment while they're sort of afflicted by this is very much specific to symptoms. So do they have proteinuria? Do they have hypertension? Do they have edema? Those types of things. And you're just sort of treating the symptoms while you're letting the disease sort of run its course. Okay. All right. Then the next type of glomerulonephritis, which is actually kind of a version of the immune globulin A nephropathy, is another type of glomerulonephritis. Let me make sure I say this in the correct German pronunciation. Enoch-Schönlein purpura nephritis. Okay, so remember when we talked about what purpura is? We talked about this when we talked about like vascular issues and sort of the vascular system issues. And I remember what purpura is. Mm-hmm. Yeah, it's those sort of small little microcapillary bleeding that kind of looks like these purple sort of splots, or not even bruises. It doesn't look like a bruise. It's like these little purple sort of hemorrhages under the skin. So that's what purpura is. Now this is a purpura that sort of affects the nephron. So what do you think that would look like? What do you think? It's a systemic vasculitis, but it's specifically purpura nephritis. So it's purpura that occurs in the nephron. What do you think might happen? Well, first of all, you're going to see inflammation and damage to those glomerular blood vessels. Okay? That's kind of a given. But what do you think symptomatology would be then if you've got damage and sort of little small microcapillary bleeding going on in the nephron, or in the glomerulus specifically? What do you think you're going to see? Yeah, you're going to see frank amounts of sort of gross blood in the urine. So pretty profound hematuria is what you're going to see with these guys, especially in children. If this happens in a pediatric population, the children have sort of, it seems to have sort of more gross hematuria. Again, with this type of glomerular nephritis, treatment is supportive. It is self-limiting, luckily. The kidney damage is usually pretty insignificant once it sort of runs its course. You're not going to see a lot of long-term issues or long-term sequela with this type of glomerular nephritis. But you can imagine, as a parent of a young child who, I mean, it looks like there's just blood coming out when they're urinating. It can be pretty frightening. So you're certainly, doing a lot of teaching, doing a lot of education to the parent, to the child. But again, letting them know that this is self-limiting. It usually does run its course, and the damage, sort of permanent damage, is usually pretty insignificant. As scary as it looks, it usually ends up being pretty insignificant. Okay. The next one is nephrotic syndrome. Now, let me be clear a little bit here about nephrotic syndrome. It's sort of this complex sort of accumulation of symptoms that you may see because of some type of glomerular nephritis. So it technically is a glomerular nephritis, but it's more sort of this conversation about a bunch of different symptoms that you see. So sort of the symptomatology complex that you see with a lot of glomerular nephritis. So again, nephrotic syndrome is a symptom complex related to loss of protein in the urine. So, characterized by severe proteinuria and hypoalbuminemia. Now again, does that relationship between seeing a lot of protein in the urine and having hypoalbuminemia, so less, low levels of albumin in the blood, make sense to you, right? Because again, I want to be clear, especially during this sort of renal content that we're talking about, hopefully now, because you know how the nephron works and you know how that movement from, tubule to blood, blood to tubule works, that you kind of have to understand that whatever the content is in the tubules, or in the urine specifically, I should say, it's going to kind of be the opposite in the blood, right? Because whatever you've lost from the urine, it means it went to the blood. And whatever you've lost in the blood, it means it went to the urine, right? Through that tubular sort of absorption and secretion process. So I hope that makes sense. In this case, we're talking, and specifically nephrotic syndrome, we're talking about the issue of protein and where it is located. But again, that's the same thing if you're talking about sodium, if you're talking about other electrolytes. If it's heavy in the blood, it's going to be pretty low in the urine, and vice versa. I want you to understand that relationship. And I hope that's clear to you now that you sort of understand sort of how it works under normal circumstances. So you're going to see proteinuria and hypoalbuminemia. And sort of the patho of why nephrotic syndrome occurs in a glomerular nephritis is sort of a lot of different reasons. So as you see here on the screen, metabolic, biochemical, physiochemical disturbances in that glomerular membrane lead to that increased permeability to protein, and that basically that loss of protein. Greater susceptibility to infection is very common in people who have nephrotic syndrome. It can be either a primary or a secondary reason for why nephrotic syndrome occurs. I will honestly tell you the patho of primary is basically unknown, kind of idiopathic reason for why someone would just kind of spontaneously have nephrotic syndrome and have this damage to their glomeruli. Secondary usually results from some sort of either systemic disease or some sort of toxic sort of drug effect that has now occurred to the kidney. So some of those interstitial sort of damage to the kidney that we talked about with drugs and toxins from Monday could certainly cause sort of a secondary nephrotic syndrome. So again, if you've got low protein in your blood, what are you going to see? Symptomatology, what are you going to see? Edema, right. Interestingly, with nephrotic syndrome, it's very common to see sort of periorbital edema. So these people with nephrotic syndrome will wake up in the morning with their eyes basically swollen shut. And then as they sit up and sort of let gravity sort of take effect as the morning wears on, some of that periorbital edema around their eyes sort of drains and subsides, and they don't look like they've got two, swollen shut eyes. But very commonly you'll see periorbital edema. And then, again, because of fluid leaking into places that should not be going, because of the lack of protein in the capillaries to create that oncotic pressure, you're going to see fluid in other weird places. So you're going to see a greater risk for pleural effusion. So remember, what would a pleural effusion be? Anyone know? So remember those pleural membranes, those bilayer pleural membranes that sort of coat the outer part of the lungs? And there's supposed to be a little bit of liquid in there to prevent friction, but not a lot. You can actually see fluid building up in that little space around the lungs because of the lack of plasma proteins to hold that fluid in, and it all leaks out into that space around the lungs. You can also see the same thing with the pericardial sac. So remember those two pericardial membranes around the heart as well. So you can see a pericardial effusion. Again, because of there's no proteins in the blood. There's nothing there to help hold that fluid in. So it leaks out into weird sort of extracellular spaces. And then you'll quite oftentimes see their urine not only being diminished, but what is being urinated out looking very frothy and foamy and kind of, frothy and foamy. Very smoothie-like, kind of that sort of frothy, bubbly look. Why? Why would their urine look foamy and frothy? Because of the excess protein in the urine. Exactly. Because of the excess protein, it gives that sort of foamy, frothy type appearance. And that's classic for nephrotic syndrome. Very good. All right. Any questions about nephrotic syndrome? I really only have devoted one slide to nephrotic syndrome, but it's pretty complex. But again, if you understand that relationship of protein and how it gets shared between the blood and the urine, it should the sort of complexity and the pathophysiology of what you're seeing sort of symptomatology speaking should make sense to you. Was there a question over here, or are you just stretching? Okay. All right. So that's it for nephrotic syndrome. Last one of the glomerulonephritis is hemolytic uremic syndrome, HUS. So this is kind of also a subtype of glomerulonephritis, but this is a little bit different than the ones we've talked about previously. So this one, as you see here from the screen, is characterized by some things that we didn't see in the other forms. So characterized by hemolytic anemia, thrombocytopenia, and acute renal failure. So that's kind of the same as the other ones, but the hemolytic anemia and the thrombocytopenia are a little bit different. Interesting, it's the most common cause of acute renal failure in children. And again, kind of like what we've seen with the other glomerulonephritis, is that it's oftentimes associated with some type of infection, some type of previous infection, be it either bacterial or viral agents that can cause this. Interestingly, it's more common in girls than in boys. Why do you think that might be? If it's especially associated with some type of bacteria or some sort of infectious agent. The shorter urethra, right? More common in girls because it results from the presence of that perineal bacteria sort of getting up into the urinary tract system, but then also entering into the bloodstream. And settling into both the bloodstream and the urinary tract. So girls are more at risk for this specific type of glomerulonephritis. Okay. Oh, and to be clear, when I say acute renal failure, you see it a couple of times here on the slide, I want to be clear that I also really mean by that, so you can sort of use that interchangeably with acute kidney injury. And those are what we talked about, last class on Monday. So meaning pre, intra, or post. So I just want you to know that you kind of use that term acute renal failure and acute kidney injury sort of interchangeably. Just wanted to be clear about that, which is different, obviously, than the chronic kidney disease or renal failure that we talked about last on Monday. So just wanted to be clear about that. In this case, with hemolytic uremic syndrome or any of these other types of glomerulonephritis, if it's acute kidney injury that it causes, what kind of acute kidney injury would it cause? Intra, because it's an actual tissue problem with the glomeruli, with the tubules, with whatever. So all of these glomerulonephritis examples would cause a intrarenal acute kidney injury. Just wanted to sort of create that sort of relationship for you. Okay. Okay, so the reason that you're going to see what you see in hemolytic uremic syndrome, which is different than the other kinds, is that the bacterial toxin, usually from E. coli, damages not only the endothelial cells of the glomerulus, but also damages red blood cells and sometimes platelets. So not only is it damaging the endothelial cells of the glomerulus in the kidney, but now it's starting to damage some of the blood cells, like red blood cells and platelets. So the endothelial lining, when it becomes damaged, becomes swollen and kind of gets occluded with fibrin clots. And these narrowed vessels, so the narrowed glomeruli that are getting sort of occluded with these little microclots, actually damages the red blood cells as it tries to pass through the glomerulus. So it actually kind of damages or even breaks down some of those red blood cells. So that's why it damages both the endothelial cells and also some of the blood cells, is because the endothelial cells get damaged, clots form around them, and then as the blood cells try to move through that damaged and sort of clotted, obstructed glomerulus, it breaks down those red blood cells as they try to fit through those small little spaces. It sort of breaks them up, hemolyzes them, okay? So that being said, now the damaged red blood cells, what happens normally to red blood cells when they get damaged? Where do they go? What happens to them? They get filtered out by the spleen, right? The spleen takes care of all those dead or damaged cells. And so now that's what causes the anemia. Because you've damaged the red blood cells by them trying to squeeze through the glomeruli. And now they get damaged, so the spleen takes them out of circulation and causes lack of red blood cells, anemia. So that's what we call acute hemolytic anemia. And that's why this particular type of glomerulonephritis causes both the normal sort of kidney issues and it causes anemia. And that's exactly sort of why. The damaged microcirculation develops a lot of different thrombi that sort of break down those cells as they try to move through. All right. Just like anything, there can be sort of a varying degree of vascular occlusion of these glomeruli. So it can really cause altered renal perfusion and renal insufficiency or failure, depending on how bad that damage and those clots are in the glomerulus. So I just want to sort of make that clear to you as well. It sort of runs on a continuum of how much this actually can impact or affect the patients with this. So again, these manifestations should make sense to you, right? Pallor, bruising or purpura because of the issues with perhaps the platelets. Oliguria, again, because you're having a lack of filtration, a lack of sort of proper function of those glomeruli. And then you can see some other things here as well. Why might you see the mild jaundice? Why would you see someone with hemolytic anemia look kind of yellow and sallow? Mm-hmm. Perfect. Right. It's because of the increased level of bilirubin in the blood because of that breakdown or that hemolysis of the red blood cells. Very good. Very good. All right. Interestingly, seizures and this overall sort of change in consciousness, or change in level of consciousness or lethargy can also happen in really sort of severe forms of hemolytic uremic syndrome because it can actually involve the central nervous system. So it can impact some of the cells of the central nervous system as well. But usually you're going to see it more impact either the circulatory system, aka sort of the blood cells, and then of course the kidneys. But if renal failure is going to occur with hemolytic uremic syndrome, it's going to happen pretty quickly. It's going to be pretty apparent within the first few days of onset, causing, again, all of those things that we've talked about, all the symptoms that we've talked about with renal failure, metabolic acidosis, azotemia, a high K, hypertension, etc. Again, oftentimes most children will recover. It can be self-limiting. Some will develop and sort of go into full-blown sort of chronic kidney failure. Again, depending on, remember I said there's different varying degrees of damage If so many glomerulus have been affected and sort of damaged and now sort of dead, you're going to move into sort of more of a chronic kidney failure. But that's usually not the case. It usually is pretty self-limiting. So management usually is pretty supportive. So early and frequent dialysis if renal failure does occur. And I don't mean for their whole life. I mean short-term dialysis while the acute sort of symptoms are occurring. And then obviously because they have hemolytic anemia and they can be pretty profoundly anemic, oftentimes another big sort of symptom treatment is just giving them, blood transfusions of packed red blood cells. So two really common sort of management devices for hemolytic uremic syndrome. Okay. Treatment for these, as you can see, are a little bit more involved than some of the other types of glomerular nephritis, but again, I hopefully should make sense to you in terms of the pathophysiology, why management is more involved. All right. Any questions about any of the subtypes or any of the forms of glomerular nephritis before we move on? Any questions about those? Okay. Now we're going to totally change gears, and we're going to talk about urinary tract infections. We did not have the opportunity to sort of really get into that with the adult population, so here's a good opportunity to do that now. We clearly know that urinary tract infections can impact both children and adults, usually for different reasons. The reasons that adults get UTIs may be a little bit different than the reason that pediatric patients get UTIs. UTIs are very common, especially in girls, because of the reasons that we've talked about already, but very common in a 7 to 11 year age range. E. coli is usually the most common pathogen because it ascends either up the urethra into the bladder to cause cystitis, or go even further up the chain, so to speak, and go past the bladder into the ureters, which then gets into the kidneys. And a kidney infection is called pyelonephritis. Or you'll hear it referred to as pyelo, quite commonly, clinically speaking. So again, cystitis is a bladder infection. Pyelonephritis is a kidney infection. Okay? Want to make that clear to you. So again, cystitis is a bladder infection. It results in the mucosal inflammation and congestion. And did you know that in a bladder infection with cystitis, it causes detrusor muscle sort of hyperactivity or irritability. So the detrusor muscle is basically the muscle that makes up the bladder as a sac. So does that make perfect sense to you then? If it causes an increased hyperactivity of that muscle, why when you have a UTI, you feel that sort of that constant feeling to void, that frequency, that urgency, that basically that constant feeling of either needing to go or need to go quickly, can't wait sort of feeling. It really does have to do with that hyperactivity of that muscle that actually physically decreases the bladder capacity. It actually sort of clamps down and contracts the bladder to make it literally smaller and inflamed. And that's why you feel like you constantly have to go with a bladder infection. So that patho should sort of hopefully make sense to you now. So that's cystitis, a bladder infection. Now, acute and/or chronic pyelonephritis, again, is a kidney infection. Anyone who's had a kidney infection knows that it makes you feel like crap. Way more so than, a bladder infection. So chills, high spiked fever. Oftentimes you'll see sort of the kind of chills that make you sort of shake. Sort of the chills that just you can't stop shaking. Really pretty extreme, excruciating flank or abdominal pain. That oftentimes what occurs because of the kidneys being enlarged and inflamed, and causing that sort of inflammatory edema in that tissue is very painful. What's interesting though, so that's usually sort of the signs and symptoms of acute. Interestingly though, with someone with chronic pyelonephritis who kind of always lives with a kidney infection, oftentimes it can be asymptomatic. A population of patients that I can think of that might be more at risk for chronic pyelonephritis would be like a spinal cord injury patient who does not have, bowel and bladder control and either constantly has an indwelling catheter in or does sort of intermittent straight caths a lot. They're so at risk for UTIs because of the, catheter sort of in and out all the time. And oftentimes those people, not only because they're neurologically damaged and can't feel, but oftentimes they are asymptomatic. because they have such a chronic state of pyelonephritis, a chronic state of kidney infections. But most commonly, under acute situations, it's all of those signs and symptoms that you'll see there. Acutely, if someone comes in, let's say, into the ED with these types of signs and symptoms, chills, high fever, flank pain, etc., the first sort of thing we'll do to sort of diagnose is to just do like a urinalysis, just like the dipstick. Anybody done those or have experience doing those? Usually what's going to come up, not only with cystitis, but also pyelonephritis as well, what's going to be abnormal in a urinalysis is the nitrates are going to be elevated. There's going to be leukocytes, there's going to be white blood cells in the urine, and then there's going to be blood. Either gross, gross frank blood that you can actually see in the urine, or just sort of occult blood that it just shows positive when you dip it. But you're not actually sort of seeing blood. So that's obviously sort of the first line of sort of diagnosis, is something quick and easy like a urinalysis. But oftentimes if we're concerned or pretty suspicious that this is either a cystitis or a pyelonephritis, we'll do a urine culture. And that's your true diagnosis, because it's going to tell you exactly what kind of bug it is, what kind of bacteria it is, and how to treat it. And you're usually treating either one of these with an antibiotic. Now, also interestingly, I said you kind of see people with UTIs for different reasons. If you're talking about pediatric population versus adult population. Bacteria is certainly the big one for both pediatric and adult. But especially with pyelonephritis, I actually see pyelonephritis a lot in the ED, specifically with women with STDs that have not been treated, because those infectious agents can actually get up into the urinary tract system, get into the bladder, and usually it's more than just a cystitis with an untreated STD. It's usually a pretty profound pyelonephritis. So I see pyelo a lot and associated with untreated or prolonged STDs, especially in women. Okay. And I think we will stop there. We will finish up with vesicoureteral reflux and just talking a little bit about enuresis on Monday. It'll literally just be a few minutes, and then we'll do our case studies again. Again, remember, case studies are for a grade. I ask you to be professional, to rate everyone in a fair, sort of across-the-board way. And again, I know there's been questions or been issues about sort of peer evaluation. But the thing is that when you get into the real world and you're working on floors, there's a lot of that goes on. And it's an important skill to sort of learn and to hone and to sort of be good at. And that's why we do it here. I don't just do it just so that you have a grade and you have some scores to put into the grade book. But there really is a purpose and a function to it. So I want you to take it seriously. I want you to be thoughtful as you answer the questions. I want you to be fair. I want you to be professional. And it really is a good way to not only sort of, create that sort of environment that you'll be doing a lot in the real world, but also, again, it is for points. So I want you to take it seriously as well. So remember, that is for points if you turn it in on time on Monday. And I hope you guys have a great weekend. See you later.